Hello everybody, this is Dr. Muhammad Hassan, Assistant Professor of Physiology, Faculty of Medicine, Ain Shams University. We will study today the term cardiac arrhythmia or dysrhythmia. What is arrhythmia? It is any disturbance of normal sinus rhythm. It may be due to difference or disorder of impulse formation or due to abnormal impulse conduction. The arrhythmia again may be due to disturbance of impulse formation or due to abnormal electric conduction of the impulse. There are different types of arrhythmias as will be discussed later. And the classification of arrhythmias may be due to disturbance due to impulse formation, such as the first type is sinus arrhythmia. Yes, the sinus, the rhythm may be sinus, but it is called arrhythmia. It is for sure a type of normal arrhythmia, because arrhythmia is not at all pathological. It may be sometimes physiological, such as the sinus tachycardia or sinus bradycardia, or even the respiratory sinus arrhythmia. All of us may have tachycardia in some situations, such as exercise or anxiety or sympathetic stimulation, or bradycardia during sleep or vagal stimulation. And the respiratory sinus arrhythmia is normal arrhythmia occur during respiration, which is an important normal biological function, as you know. And the second type of the impulse formation disorder is the AV nodal rhythm. The AV node may be the pacemaker in some situations. And the third one is arrhythmia due to the presence of what is called an ectopic focus. But the way ectopic focus is a pathological condition. The appearance of ectopic focus, it is a pathological condition. The ectopic focus is a cell that was not pacemaker, but in pathological conditions, they appear to be to having an autorhythmic activity and will be pacemaker tissues. If the ectopic focus would present in the atria, it is called supraventricular arrhythmia. And if it goes in the ventricle, it will cause what is called ventricular arrhythmia. And so we have three types of arrhythmia according to the presence of the pacemaker of the heart. When the pacemaker is the SC node, it will be a sinus arrhythmia. When the AV node is the pacemaker, it will be AV nodal rhythm. And when the ectopic focus appeared even in the atrium or the ventricle, it will be supraventricular or ventricular arrhythmias. Arrhythmia is due to disturbance of conduction, of impulse conduction. It is the second type of arrhythmia, according to the classification of arrhythmia due to impulse formation, the first type, and due to impulse conduction is the second one. The disturbed impulse conduction may be accelerated conduction through the AV node, and it is called Wolff-Parkinson-White syndrome. Or due to slowed conduction or transformation block in the AV node, and it will be of different types, such as AV heart block or bundle branch block. One of the bundle branches blocked right or left, or the sick sinus syndrome, where the SE node from the start, its conduction to the conducting system is blocked. And so impulse conduction may be classified according to its velocity. If accelerated, such as Wolff-Parkinson-White syndrome, to the first type, and if slowed, such as sick sinus syndrome, AV heart block, or bundle branch block. Sinus rhythm and sinus arrhythmia, it is the first type of all types of arrhythmia. It is a normal, it is just the normal type of arrhythmia. We have now different criteria of the sinus rhythm before the appearance of arrhythmia. The sinus rhythm, the P waves should be upward and in the normal standard leads, as you know, lead 1 and lead 2 and lead AVF and so on, which are upright, as you know, or inverted in the EVR. It is a normal criteria of the ECG. the P wave should be upward, and the PR interval should be more than 0.12 second. It is the maximum length of the PR interval. When it is prolonged, as the PR interval, now we have a problem, which may be the presence of the ectopic focus away from the SE node, because it will take a long distance to reach the ventricles. Or due to disturbance of conduction, which will be discussed later. But now the normal sinus rhythm, the PR interval shouldn't exceed the normal value, which is 0.12 seconds through 3 small squares, I mean. And the third criteria of the normal sinus rhythm, that the heart rate should be between 60 and 100 beats per minute. When these criteria collect together, it is a normal sinus rhythm without arrhythmia. The P wave is upward, and the QRS interval, the QRS should be normal in shape also. The PR interval doesn't exceed 0.12 second. Heart rate should be between 60 and 100 rates of beats per minute. Now, the first, the sinus arrhythmia, sinus tachycardia, which is normal during sympathetic stimulation, fear, fight, fright, or during exercise, or drug induced, and so on. But the sinus SA node remained the pacemaker of the heart. Now the same criteria were preserved of the ECG. Same criteria were preserved, but the heart rate exceeds the 100 beats per minute. It is only the normal, the abnormal, or the change of the normal sinus rhythm. So we have now normal P wave, normal QRS complex, normal T wave, but shortened RR interval, which is the duration of the cardiac cycle. So we have a lot of QRS complexes, but regular. This is the normal shape of the sinus tachycardia. Ticker that the P wave is normal in shape. The PR interval now is normal between 0.12 and 0.21 second. The QRS complex is normal in shape and narrow in shape, and doesn't take the bizarre shape. The bizarre shape means wide and abnormal shape, the QRS, but now the QRS complex is normal in shape. The heart rate is regular, as you see that the RR intervals are equal between different R waves are equal. So we have regular ECG and with normal criteria. But when you collect the heart rate from this image, you will see that it exceeds the 100, so it is called sinus tachycardia. Likewise, this is sinus tachycardia also. Everything is normal, P wave, QRS, and T shape. The ECG is regular, and the PR interval is normal, doesn't exceed the 0.2 second, but the heart rate exceeds the 100, as you see, 130 beats per minute. Sinus tachycardia. Okay, sinus bradycardia means that the heart rate is less than 60 beats per minute. Now we have another type of sinus rhythm, which is normal also, sinus bradycardia. The SA node is the pacemaker, and didn't change. Everything will be normal. The P wave, the QRS complex, and T wave shapes. It will be regular in shape, but the RR interval is long because the heart rate, or leads to the heart rate to be less than 60 beats per minute, such as this condition. You see that the RR interval is very long, and so the heart rate now is low, about 30 beats per minute, but it is regular. The RR intervals between different R waves are equal. The normal shape, the P wave, the normal shape, the QRS, and the normal shape, the T wave should be observed in this consideration. Okay. This is a sinus bradycardia again. Everything is okay, but the RR interval is long and the heart rate is less than 60 beats per minute. Different ECGs of the sinus bradycardia. And the third one of sinus arrhythmia is the respiratory sinus arrhythmia. Respiratory sinus arrhythmia means that heart rate during inspiration, this is during inspiration, is more than the heart rate during expiration. Look to the RR interval here, which are equal during inspiration and regular, but short. As you see that the RR interval is short. But look during expiration, this is the RR interval, which is long. The RR interval is long during expiration. That means that the heart rate during inspiration is more than the heart rate during expiration, but it is regular during inspiration with normal shaped P and QRS complexes and T waves, and everything is okay, but the heart rate during inspiration differs from the heart rate during expiration, but it is also regular and normal shaped during the expiration. The heart rate during inspiration, for example, may be 80, and during expiration may be 100. And so we have different rates because of the different vagal tone. The vagal tone decreases during inspiration, so the heart rate is increased during inspiration, but the vagal tone is increased during expiration. I'm sorry, but the example I said is the opposite. The heart rate during inspiration about 100 and during expiration about 80. Yeah, I mean that the heart rate is dropped somewhat during expiration because of the increased vagal tone. And it is clear now by the long RR intervals. Okay, again, uh, this is heart rate during inspiration, which is more than the heart rate during expiration. Look here, the RR interval is very long, as you see. But there is what is called sick sinus syndrome may appear in some situations, but such as an elderly person. An elderly person, the heart rate dropped about 40 or 43, 43, 43, and now it may stop for a time. It's called sick sinus syndrome. You should know that the SE node may work, but it cannot stimulate the conductive system. So it is a conductive disorder more than an impulse formation disorder. And we will discuss it again in the disturbance of impulse conduction. Now we will discuss if the pacemaker was not the SE node, if the pacemaker was an ectopic focus. We have premature beat. It is the simplest form of pathological arrhythmias. It is pathological, but may appear also during anxiety or due to caffeine and so on, which stimulate the excitability or the excitable tissues of the heart. It is not a dangerous situation. But when the person is anxious and the anxiety or irritability may form this type of arrhythmia. When the person feels an abnormal beat in his heart, he should be insured and take some rest from his stresses and stop caffeine, stop smoking as much as he can. Okay, premature beats, premature atrial contractions, or AV nodal premature contractions or beats, or premature ventricular contraction. As you see that according to the site of the ectopic focus, the premature beats are classified. Premature beat. Look here. Now, this is a premature atrial contraction. This is a premature atrial contraction. This is a normal impulse, normal P, normal PR interval, normal QRS complex, normal T wave, and so on. And this is another normal one, third normal one, fourth normal one, and so on. But this one is abnormal because the premature beat comes near to the previous normal beat and to somewhat far from the normal beat. This premature beat normally comes here. This is the presence of should be, the P wave should be here. But because it is premature, the P wave comes early, as you see in this point, or at this point of the ECG. Now we have different criteria of the premature beat. First one, that the P wave is abnormal in shape. It is inverted, as you see, because ectopic focus is not the SA node, and so its direction may be falls from right to left and from downward to upward according to the presence of ectopic focus. Abnormal shaped P wave. Abnormal PR interval may be present also according to the presence of the ectopic focus. If it is near to the AV node, we will have short PR interval. If it is far from the AV node, it will be a long PR interval, and so on. But we have normal shaped QRS complex. Why the QRS complex is normal in the premature atrial contraction or premature beat? Because the impulse direction in the ventricle is normal. Don't miss that the ectopic focus is present in the atrium, the supraventricular, and so it will pass to the ventricle through the AV node and will take the normal passage of impulse conduction through the bundle FS and bundle branches, then Purkinje fibers. So we have a normal electric conduction distribution in the ventricles. Therefore, we have a normal shaped QRS complex. But look to the RR interval before it is short, and the RR interval after the premature beat, it is long. But when we gather the RR interval before and the RR interval after, we have a normal gathering or sum of two normal RR intervals. When we, for example, the RR interval here, 1, 2, 3, 4 large squares. So the two RR intervals will be 4 plus 4 means 8 squared. So we have the before the RR interval before the normal premature beat, if they are 3 squares, large squares, and the after will be 5 large squares. So 3 plus 5 also equals 8, like the normal two RR intervals. This is the premature beat, and these are the normal criteria of the premature beat. By the way, it is a misnomer to name the premature beat by the word or the term atrial extrasystole. It is a misnomer because it is normally not an actually extrasystole. It's just a premature beat, comes early before its normal time. Its normal time, as I said, would be come here or there and so on. Okay. This is one premature beat, and this is a second premature beat, which may appear many times during 1 minute, but doesn't exceed 10 times. This is a normal. This is the ECG changes during the premature atrial contraction. Abnormal P wave, PR interval mostly shortened because the ectopic focus is mostly near to the AV node. QRS and T waves are normal because of the normal distribution of the impulse in the ventricles, and the premature atrial contraction may be followed by the long period between it and the normal beat. Later on, it is called a compensatory pause, which may be present. Okay. And this is just a training to look for the two premature beats. This is one, and this is the second one. Premature beat here is this one. This is normal, and this is normal, and this is normal. This is regular. Normal P, normal QRS, normal T, and the normal RR interval. Yes, but this is the abnormal one, the abnormal premature beat coming early and showing no P wave or abnormal P wave and normal shaped QRST complex and the duration before is short and the duration after is long, which is called the compensatory pause, and may be present this compensatory pause and so on. The ectopic focus may be present in the ventricles, and it will cause what is called the ventricular premature beat, premature ventricular contraction, premature ventricular contraction or beat, or a ventricular extrasystole. It is one word. Oh, now we will see the abnormal beat, which is premature, and the ectopic focus now is ventricular. Look now, this is the normal beat coming from the SE node. This is the normal P, normal PR, and normal QRS complex. This is normal beat, but this is the abnormal beat. This is the abnormal. Now we have a QRS complex. This wave is called the QRS complex. It is bizarre shape. It is not narrow like this one. It is very large like one. Look to the T wave in the normal beat. It is upright. Look to the T wave in the abnormal beat, or the bizarre shaped QRS complex is inverted. So the bizarre shaped QRS complex is a complex of wide QRS, more than 3 small squares, more than 0.12, and very long compared to the normal one, and associated with inverted T wave. So this is called the bizarre shaped QRS complex. Okay, why the QRS complex is bizarre shaped? Why it is long, what is large, wide, and T wave is inverted, and so on. This is because of the abnormal wave conduction in the ventricle, because the pacemaker of the ventricle at this point of time is the ectopic focus and not the SE node as usual. When the impulse direction of impulse, when the direction of impulse is inverted or abnormal, and will not take the normal passage of the bundle of S bundle branches and the Purkinje fibers, it will take a very long time because it will pass from cell to cell, which is a shorter conduction compared to the normal conductive system, as you know. Okay, you should see also that the abnormal beat, this is the abnormal beat, is near to the previous normal beat and far from the following normal beat. This is a compensatory pause. This is a compensatory pause. Yes. By the way, the normal beat of ECG of the P wave of the SE node coming from the SE node, I mean, this is normal one, and this is the time of the normal one, the second normal one, but we cannot see it because during the sinus stimulation now the ventricle was suffering from the bizarre shaped QRS complex, which takes a very long time, and when there is an electric event occurring at the atria and another one occurring at the ventricles, the ventricular electric activity masks what occurs at the atrium. Okay, so the normal beat which come here is masked or doesn't present, as you see. We have a normal beat, then a premature ventricular beat, then a third beat. The premature beat is usually weak because weak in contraction, because I don't mean weak in the electric response, no, weak in contraction. When the ventricle contracts in response to this premature beat, it will be a weak contraction because the time passed from the preceding beat and the abnormal beat, premature beat, is short. So the ventricular filling will be little than normal. And when the ventricular filling is little, the ventricular contraction will be weaker. But there is a long time passed from the premature beat to the normal beat following it. so the ventricular filling will be more than usual, and the ventricle will be filled by a lot of blood, giving a very strong beat, very strong beat. So the beat following the premature beat is a very strong, and this is the beat that will be felt by the patient. The patient is coming for you as a doctor, suffering from or complaining from a very strong beat which occurs suddenly in his heart. Okay, the premature ventricular beat doesn't contain P wave. Why no P wave in the premature ventricular contraction? Because the ventricle now is responding to an impulse coming from the ectopic focus present in the ventricles. And for sure, the ectopic focus in the ventricle, when it is present in the ventricle, it cannot stimulate the atrium because of the presence of the EV node, which one of its functions is the unidirectional passage of impulse. It permits the impulse conduction from the atria to ventricles and doesn't permit the impulse conduction from ventricles to atrium. To sum up, we have now a premature ventricular beat characterized by no P wave, bizarre shaped QRS, long and wide, inverted T, is called the bizarre shape. We have a compensatory pause, followed by strong P. The response to this QRS complex for the ventricle will be a strong premature beat, compensatory pause, and strong beat, followed by strong beat. Again, every 2 RR intervals, the sum of the 2 RR intervals equals the sum of the normal 2 RR intervals. Okay, this is a premature beat, as you see. This is another one, premature, when the QRS complex, as you see, is bizarre shape, abnormal shape, deep, wide, inverted T compared to the QRS complex, or this one, as you see, is a premature ventricular contraction. Different trainings about the premature ventricular contraction. Yes, different shapes. Another one. You can focus on it just when you see the ECG. It will be clear as clearly this one and this one and so on. Okay. When the AV node giving the premature beat, the AV junctional beat or rhythm. When the AV node is the pacemaker, now it will stimulate the atrium inversely, so we will have an inverted P wave and normal shaped QRS complex because the passage of impulse in the ventricle is now passed from the atria from above downwards through the bundle of Hess and Purkinje fibers. So the P wave is inverted. The QRS complex is normal in shape, and the PR interval is very short PR interval because the atrioventricular conduction is very short. The AV node is the pacemaker, and the atrioventricular conduction will be shorter than when the pacemaker is the SA node for sure. Look here, please. This is the abnormal beat. This is the preceding normal beat, B normal, QRS complex normal, T wave normal, and this is a premature beat coming earlier than usual. And the B wave now is inverted, as you see. The PR interval is very short. Look to this one is longer, but here it's shorter. And we have a normal shaped QRS complex narrow, just two small squares of 0.8, as you see, a normal shaped wave. So we have a premature junctional or AV nodal beat. We have a small RR interval before and the longer one after it. It's a compensatory pause and stronger beat as usual in each type of premature beat. This is another one. This is another one, premature beat. Okay. Another type which is more dangerous than the premature contractions may be a safe type of arrhythmia due to anxiety, over sympathetic stimulation, due to irritability, caffeine, smoking, and so on. But when the condition is more severe, another type of arrhythmia is called paroxysmal attacks. Paroxysm, uh, paroxysm means a period of time, not one beat, not one beat. There is arrhythmia for a period of time, which may be seconds, minutes, or even very long, very long duration. Even. Take months, take years, and so on. But it is not one beat. This is called the paroxysmal. Paroxysmal tachycardia may be ventricular, may be atrial, or maybe atrial or ventricular. Okay. Supraventricular means atrial, I mean. Paroxysmal supraventricular tachycardia, or more severe called atrial fibrillation, and the most severe in the atrial is called atrial flutter. The paroxysmal attack of tachycardia, the heart rate may be ranging it is one ectopic focus. It is the regular beat, but the heart rate may be about 130, 150, and so on. The paroxysmal attack of tachycardia, but we have one ectopic focus giving rhythm more than the normal sinus rhythm, 150, 160, and so on. Paroxysmal tachycardia, but it is regular. Atrial fibrillation, no, we have one ectopic focus, but its rhythm is more than 200, from 200 to 350 or 400 even. But we have now also in the atrial fibrillation one ectopic focus. The atrial flutter is the most severe type of atrial arrhythmias. Atrial flutter means that we have different ectopic foci, many ectopic foci in the atrium. And now the heart rate or the beating rate of these ectopic foci collectively may be 500, 600, or even more in some situations. It is an irregular fashion, irregular type of arrhythmia, which is the atrial flutter, and it is the most severe. You should know that different types of these pathological arrhythmias, which are severe types and which may be atrial or ventricular, may be due to ischemic heart disease, may be due to ionic disturbance, electrolyte disturbance, I mean, which are different severe conditions. Or due to what is called the re-entrance phenomenon is also due to ischemia mostly. Treatment of these types of arrhythmias is by vagal stimulation. We may suppress the atrial anxiety or atrial irritability or overstimulation. The vagus, as you know, that the vagus controls the atrium but cannot control the ventricle. When the arrhythmia present in the ventricle, such as ventricular paroxysmal ventricular tachycardia or ventricular fibrillation, the vagal stimulation cannot give a response. Or you may need cardioversion by the AC shock or the shock technique, which is very strong electric stimulation of the heart by 1,000 to 3,000 volts. But we rarely need this maneuver in the atrial arrhythmias. The paroxysmal or ectopic tachycardia, now the tachycardia is due to the presence of ectopic focus in the atria, and can be divided into two main categories: paroxysmal supraventricular tachycardia, when the ectopic focus is in the ventricle or in the atrium, I'm sorry, or paroxysmal ventricular tachycardia when the ectopic focus is present in the ventricles. Okay, look now to the paroxysmal supraventricular or atrial tachycardia. Paroxysm, I said it is a long time and not one abnormal rhythm. Look now to the normal beating before the appearance of the paroxysmal attack of tachycardia. It is normal, BQRS complexes, it is regular, the duration between different RR waves is equal, and the heart rate now is about 70, for example. But look when the arrhythmia appeared. This is arrhythmia. The heart rate is increased, but it is regular also. Uh, it is general idea or concept. When the ectopic focus is 1 ectopic focus, the heart rate will be regular. When it is more than 1, such as at atrial flutter, as atrial fibrillation, I'm sorry, it will be irregular. We have now 1 ectopic focus, so we have regular ECG, regular but fast, compared to the normal RR intervals and normal heart rate before the arrhythmia. Look to the P wave here. It was the normal shaped P waves. It was a pacemaker, but now the P waves may be absent because of the fast QRS complexes, which may mask the P waves, or if appeared, it will be inverted. Will be inverted if appeared, because the ectopic focus giving an abnormal conduction passage in the atria from left to right or from downward upward according to its site. So we have regular QRS complexes, normal shaped QRS complexes. Don't miss that. The QRS complex is normal shape because the impulse will pass from this ectopic focus at the atria to the ventricles, to the AV node, and then to the normal conductive system at the ventricles. Normal shaped QRS complexes, regular QRS complexes, but fast QRS complexes compared to the normal beating rhythm, and there are no B waves or abnormal shaped F present. And the heart rate now is about 130 or 150. It is more than the normal rhythm, as you see. This is a normal, this is a usual heart rate during paroxysmal supraventricular tachycardia, 140 to 220. This is the usual rate of paroxysmal attack. Just for training, this is a normal beating, and this is abnormal paroxysmal atrial tachycardia. The heart rate arises from 74 before beat per minute to 148 beat per minute after the abnormal rhythm. But it is regular, as you see, because of the norm. We have only 1 ectopic focus. The B waves were normal before, and then no P waves appeared after, because the P waves may be masked by the QRST complexes, which are fast and rapid and numerous. So they may mask the P waves arising from the SMA or arising from the normal region. PR interval is normal, and QRS duration is normal. It is a paroxysmal attack. This is another type, another shape of the paroxysmal supraventricular tachycardia. Look here at this very long, very fast QRS complexes, but regular, fast, 100, about 160 or 70 beat per minute, and abnormal shaped B wave. Abnormal shape, if they appear, they would be abnormal, as you see, but normal shape QRS complexes, normal shape QRS complexes, regular, and so on, is paroxysmal supraventricular tachycardia. Okay. When the ectopic focus present at the ventricles, yeah, look here, we have only when the ectopic focus at the ventricle, so the 140 beat per minute to up to 220 will all ventricular in origin. We have 1 ectopic focus at the ventricle. When we have 1 ectopic focus at the ventricle, it will be regular, but abnormal shape. Regular means that the distance or the RR intervals are equal, but look to the QRS complex. Is it normal in shape? No, it is bizarre shape. long duration and high in voltage compared and inverted T. This is the T waves, but inverted. But now we have no P waves appeared because of the very numerous QRS complexes in the ventricles, and the wide QRS complex for sure will mask the T wave. So we have only regular abnormal shaped, very fast QRS complexes. This is for sure ventricular, paroxysmal ventricular tachycardia. The rate now is 160 regular rhythm. The P wave non-PR interval none because we cannot see the P wave, and the QRS duration is wide. It is a bizarre shape, more than the three small squares, more than 0.12 seconds. I mean, interpretation, it is a ventricular paroxysmal tachycardia. Yes, this is a ventricular tachycardia. There's another one of ventricular tachycardia. Abnormal shape, but regular. Abnormal shape, bizarre, but regular. And no P wave appears. Yes, VTAC. All these are VTAC. VTAC means ventricular tachycardia or ventricular tachycardia. And we will discuss now the more severe condition than the paroxysmal attack. It is a flutter or fibrillation. There are two types of arrhythmias. The flutter means I have one ectopic focus, but at a rate of 200 to 400 beats in the atrium. One ectopic focus presents the atrium with a beating rate is 200 to 400. And atrial fibrillation, which is we will have multiple ectopic foci at the atrium with a rate more than 500 beats per minute, and now will be irregular. Look to this ECG. There's an atrial flutter. We have now the different criteria. These are P waves, and every 3, 1, 2, 3, 4, we will have one QRS. T. 1, 2, 3, 4, we have one QRS. And so we have a ratio between the P waves and the QRS complex. Every 4 or every 2 or 3 or 4 P waves will be synchronized or associated with one QRS complex. The P waves are normal in shape. The P waves, I'm sorry, are abnormal in shape but regular because it is an ectopic focus. We give abnormal shaped P wave and a normal shaped and irregular QRS complexes because of the passage of the impulse from the ectopic focus present at atria to the ventricle through the normal passage system. So we will have now regular but abnormal shaped P waves and with more ratio than 1:1 to the QRS complex. We have a normal shaped QRS complexes regular, as you see our intervals are regular. Okay, it is an atrial flutter. It is an atrial flutter. The appearance of the P waves like this condition because of the very fast rhythm of the ectopic focus, which between 200 or to 340 or 350 or 400 at sometimes, giving what is called the sawtooth appearance. The sawtooth appearance, it is the abnormal shape of P wave. Don't miss that the QRS complexes are regular. The P waves are regular because I have one ectopic focus at the atrium. But why not all the P waves giving QRS complexes? Why the ectopic focus cannot stimulate the ventricle at each time? Because of the AV node. Because the AV node act as a filter, cannot pass more than 150 beats per minute during arrhythmia. The AV node, as you know, have a long refractory period and so cannot pass all the abnormal atrial beats to the ventricle. So in each two P waves, we will have one QRS, or in each three P waves will have 1 QRS or more. 2 or 3 or 4 P waves will give 1 QRS complex, but at a regular fashion and equal ratio each time. The ventricular beats now will be regular and the same force and the same power, the same force of contraction, I mean, because of the equal RR intervals in between the R waves. So the regular we will have regular beats between and regular contractions of the ventricle. The sawtooth appearance of the B wave is called flutter waves. The sawtooth appearance is called flutter waves. But atrial, this is another type of another shape of atrial flutter. The sawtooth appearance. You look now, regular sawtooth appearance and regular QRS complexes, normal shaped QRS complexes is an atrial flutter. Atrial flutter, atrial flutter, atrial flutter. But this is an atrial fibrillation. Now at atrial fibrillation, no B waves, just a hesitation of the isoelectric line. Now the TP segment is irregular shape. All of these are irregularity of the different ectopic foci. We have now different ectopic foci, many ectopic foci at the atria, not one. And so we have an irregular fashion of the electric impulse conduction of the atria, giving this hesitations. These are not waves, but just juggling or hesitation of the isoelectric line. But look now to the QRS complexes that normal in shape, because when the ectopic focus present at the atria, it will pass through the AV node to the ventricle through the normal conductive system. But be careful that it is irregular. This RR interval is not equal to this one. It's not equal to the third one, and not equal to fourth one, because the atrial beats themselves are irregular. When the atrial beats are irregular, and though there is no fixed ratio between the atria and the ventricle, the ventricular beats will be irregular. And so we will have very different powers or contractions of the ventricle now. When the beats come near to each other, the beat will be weak because of the filling of blood will be little. But when the beats will come far from each other like this, the beat now will be strong because of the enough time for ventricular filling. So the ventricular beats will not equal. When we count the ventricular beats from the heart by your stethoscope on the chest, we will count all the beats, the strong and the weak, which may be 150, for example. But when you will count the heart rate from the radial pulse, from the radial artery, we will feel only the strong beats will arrive from the heart to the radial artery, and so the heart rate will not equal to the heart rate itself. But the pulse rate at the radial artery will be less, because I will feel again the strong beats also. I will feel, for example, 120 or over 150, 120 pulses, but the heart rate from the heart itself by just stethoscope in the chest was 150, for example. We will have now what is called pulsus deficit. This is a defect of the beating from the heart to the radial artery. And this condition was not found when the condition was atrial flutter. Atrial flutter, I have an equal beats of the ventricle, and so the equal beats will be all felt at the heart and all felt at the radial artery, and no pulsus deficit between them. By the way, we can find the pulsus deficit, which is a defect or a variation between the heart rate at the heart and the pulse rate at the radial artery in two conditions. First condition is extrasystole, the premature beats. The premature beats may be the premature beat itself is weak beat, but doesn't exceed 10 per minute. But at the atrial flutter fibrillation, the pulses deficit is more than 10 for sure. When we count the heart rate at the heart, it will be 150, but at the radial artery 120 or 125. So the deficit is about 30 beats per minute or 25 beats per minute. So it exceeds that 10. And so the pulses deficit, if less than 10 beats per minute, it is extrasystole or premature beat. When it exceeds the 10, it is atrial fibrillation. The beats now are irregular. We have no P waves, but fibrillation waves, fibrillation juggling or fibrillation hesitation of the isoelectric line, as you see, and with irregularity of the QRS complex, but normal in shape. This is atrial fibrillation also. And this is just a comparison between that fibrillation and flutter. Okay. Now, there is another type of arrhythmia, but the ectopic focus or foci are present now at the ventricles. We have ventricular arrhythmias, such as ventricular tachycardia or ventricular fibrillation. VTAC, ventricular tachycardia, is characterized by one ectopic focus at the ventricles, which send impulses of average 140 or 150 up to 220. The ECG rhythm is regular, as seen in this figure. It is regular, but the QRS complexes are bizarre shaped, as shown at this figure. Regular. The ECG is totally QRS complexes. There's VTAC, ventricular tachycardia, or paroxysmal ventricular tachycardia. For sure, there is no P wave present because the multiple ectopic foci, because of the high rhythm of the QRS complexes, which mask the P waves or the mask is a nodal activity. So when we have ECG, which is totally formed of regular QRS complexes, rhythm more than 140 or 50 up to 220, but regular and bizarre shaped QRS complexes without P wave, it is a form of VTAC, ventricular tachycardia. But ventricular fibrillation, which is the worst type of arrhythmias, where there's no rhythm at all, completely abnormal. And we have multiple ectopic foci, the ventricles. Multiple ectopic foci are characterized by being completely abnormal and no typical rhythm present. And the heart is now fibrillating, the ventricles are fibrillating, which is desynchronized contraction. It is preceding the cardiac arrest, and it is a severely fatal condition and very dangerous and needing the DC shock at once. This is VF, ventricular fibrillation. Ventricular fibrillation. Look to this ECG. There is no rhythm at all, and no characteristic shape, no regularity. That's shown here. This is ventricular fibrillation, which is a damaging and fatal condition. We are in need for non-pharmacological treatment as an emergency, needing the electroshock or the cardioversion. And now we will discuss the arrhythmias due to disturbed conduction. Arrhythmias due to disturbed conduction is characterized by or classified into slurred conduction or slow conduction, and the most famous one of them is the AV nodal block, or accelerated conduction. AV nodal block have different degrees: first degree, second degree, and third one. The second degree is formed of two forms, type 1 and type 2. First degree heart block, where the PR interval fixed more than 0.2 seconds. More than 0.2 seconds. Yes. Is the first degree heart block. The normal AV nodal conduction or the atrioventricular conduction should be less than 0.2, from 0.12 up to 0.2 seconds. When it is more than 0.2 seconds, it is a first degree heart block. While the second degree heart block, type 1, the PR interval gradually lengthening, then there is one drop beat. While the second degree heart block, type 2, is characterized by a fixed PR interval, but QRS is randomly dropped. We have two P's to one QRS or three P's to one QRS for sure with bradycardia. It is a heart block or decrease in the QRS complexes rhythm. While the third type, which is a complete heart block, type 3, there is no PR interval because there is no atrioventricular conduction at all. As you know, that the PR interval is characterizing the atrioventricular conduction, which is now not present. The P waves and the QRS complexes are completely dissociated. First degree heart block. This is the ECG of the first degree heart block. Look at this one. The PR interval is very long, more than 0.2 seconds, more than one large square, as seen. The PR interval from the start of the P wave to the start of the QRS complex is called the PR interval. It should be less than one large square, which is less than 0.2 seconds. Now it is more than 0.2 seconds. There is a delay of the AV nodal conduction, which is first degree heart block. The heart rate is within normal, 60 beats per minute. It is regular. Every P wave is followed by QRS complex. So the ratio between the P and the QRS complex is 1 to 1. P waves are normal in shape because the SA nodal activity is normal. But the PR interval, as seen here, is 0.23 seconds. And the QRS duration and shape is normal. This is the first degree heart block. Yes, this is another shape that first degree heart block, prolonged PR interval more than 0.2 seconds. And this is the third one. While the second degree heart block, we have two types of second degree heart block. Type 1, it's called Vinke-Bach phenomenon, but the name is not important, but you should know it is Mobitz type 1. Okay, type 1 of the second degree heart block is characterized by this is the PR interval, which is normal, while PR interval is now prolonged, and the PR interval is more and more prolonged. And this is P wave without QRS complex. So there is a progressive prolongation of the PR interval until dropped beat. Then the cycle will be repeated again. Right? The PR interval is now normal, prolonged, more and more prolonged until dropped beat. Yeah. This is type 1 of the second degree heart block. Second degree heart block, PR interval, longer, dropped. PR interval, longer, then will be dropped. While the type 2 of the second degree heart block is characterized by this is the BQRS and this is BQRS. Now the BQRS complexes now randomly with no QRS complexes. Here, no QRS complex. We have now two P waves with one QRS complex. two P waves with one QRS complex. There's a random drop of the QRS complex, not progressive prolongation as we said before, just random drop of the QRS complex. This is the second type of the second degree heart block. You should see that P, P, and P, then QRS. P, 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 then QRS. Okay. No progressive prolongation of the PR interval. No progressive prolongation of the PR interval, but there is random prolongation, random drop of the QRS complexes. It is second degree heart block. It is a type 2. There is bradycardia. You should see here that although there is a ratio between the P and the QRS complexes, 3 to 1, 3 Ps to 1 QRS complex, and we discussed before there is a ratio between the P to QRS complexes may be present in some types of ECG, such as the atrial flutter. But at the atrial flutter, there is tachycardia, while at the second degree or heart block, there is bradycardia. Look to the RR interval, and so on. There is very long RR interval indicating bradycardia. Okay. While the third degree heart block, there is no PQRS at all, and no ratio between the P and the QRS complexes. They are completely separated or dissociated. The atrium is now having a pacemaker, which is the SA node, while the ventricle is having another pacemaker, which is the ectopic focus. And as you know that the ventricular ectopic focus cannot stimulate the atrium because of the presence of the AV node. So in the third degree heart block, look now, this is RP waves, and this is a QRS complex. It's RP waves, and this is QRS complex, and no relationship between the P to QRS complexes. No relationship between the P and the QRS complexes. The P waves may come at any time, and the QRS complexes may come at any time. And for sure now, the ventricle is having a pacemaker in the ventricles itself, in the Purkinje system, which give abnormal QRS complexes, abnormal shaped. So they are bizarre shaped, as you see. But because we have one ectopic focus, they are regular. They are regular, as seen. They are regular QRS complexes, but no interrelationship between the Ps and the QRS complexes. These are the P waves, which may come before the QRS complexes, after the QRS complexes, without QRS complexes, or even at the QRS complexes themselves. So we have no relationship between the P or the QRS complexes, and the P waves will be recorded as the QRS complexes will be also recorded. The QRS complex is wide and the bizarre shaped inverted P wave because of the abnormal conduction of impulse at the ventricles. This is third degree heart block. Yes. Third degree heart block. You can see now P wave, and you can see P waves, and so on. But we have the QRS complexes completely separated from the P waves. Another image of the QRS of the third degree heart block. P here, and P there, and P here, and P there, but there is no relationship between the P waves and the QRS complexes. Another type of accelerated or slow conduction of the impulse causing arrhythmia is a bundle branch block. We may have a right bundle branch block or left bundle branch block. This is a normal conduction from the SA node to the AV node to the bundle of S, and bundle branches into the ventricles. From the SA node to the AV node, to the bundle of S, to bundle branches, and then to the Purkinje fibers. This is a normal, but when there is abnormal conduction, now one ventricle will be stimulated from the conductive system of the normal node. I mean that the SE node will stimulate the AV node, and then the bundle of Hess, which stimulates this ventricle by the normal Hess Purkinje system, and this ventricle will not be stimulated by the normal conductive system. So we will have two QRS or two R waves, one for the left ventricle, which is the normal conduction, and another R for the abnormal ventricle. Look here, this is the nodal activity, and then the AV node, bundle of S, and this is the normal bundle, and while there's right bundle branch block. This ventricle will be stimulated, giving a normal R, and then its impulse will run from this ventricle to the other cell to cell by cell to cell conduction, giving another peak of the R wave. Like this, we have a shape called M-shaped or the rapid ear shape in the right branch bundle branch block, which will appear more at the leads near to the right ventricle, which are the V1 and V2. This is the normal R, and this is the abnormal one of the abnormal ventricle conduction. We have now M-shaped QRS complex having two peaks. Bundle branch block is also characterized by an axis deviation. Why there is an axis deviation? Because the electric activity will run from one ventricle to the other. In the right bundle branch block, the electric conduction of the ventricle will run from the left ventricle having the normal bundle to the left ventricle, which is having an abnormal bundle. So the electric activity is running to the right side, from left to right, which is giving right axis deviation. In right bundle branch block, there is right axis deviation. We have also two peaks of the R wave. Two peaks of the R waves. We have two peaks. Okay. We may have inverted T wave because of the bizarre shaped QRS of the abnormal conduction of ECG. Look here at V1 and V2, there is rabbit ears or M-shaped QRS complexes, two peaks of the R wave, one normal and one abnormal, and the abnormal one is associated with inverted T wave. This is a bizarre shaped QRS having long duration and high amplitude and inverted T wave. This is a right bundle branch block giving rabbit ears shape, rabbit ears, or M shape in the V1 and V2. Or we may have a left bundle branch block, which give a left axis deviation and characterized by deep and broad S waves, and the V1 and V2 like this. Deep S waves at V1 and V2. And there is left axis deviation. While the notched R, or the two peaks of R waves, will be apparent at V5 and V6, which are near to the left ventricle. In the left ventricle, the inverted M, which is like a W, like the verb W. The letter W. While there is a third type of slow conduction or slow conduction, which is the sinus arrest, or called sick sinus syndrome, which is may be present at elderly or due to an electrolyte disturbance. There is a sudden stoppage of the SA node for a while which may lead to syncopal attacks. It is preceded by an attack of bradycardia, then sudden stoppage of the SA node for a time, which is short time, giving the syncopal attack, then it will regain its activity later on. Accelerated conduction is called Wolff-Parkinson-White syndrome. Wolff-Parkinson-White syndrome. There is a bypass of the AV node. There is a bypass of the AC node. Bypassing the AV node normally causing AV nodal delay and prolongs the PR interval to the normal duration of 0.12 to 0.2 seconds. This is the normal. But now we have no AV nodal delay. So the PR interval will be short, less than 0.1 second to 0.12. It is less than the minimum duration of the PR interval, which is 0.12 seconds. But the QRS complex is prolonged because the conduction now in the ventricles may be prolonged. There is accessory bundle bypassing the AV node and stimulate the ventricles where the impulse will be conducted from cell to cell, giving a bizarre-shaped QRS complex. So we have short PR interval but prolonged QRS duration. Now look there. This is the normal ECG. There is a PR interval, and this is the QRS complex, where its endpoint is called the G point, and this interval is called PJ interval. PJ interval. This is the normal. At the Wolff-Parkinson-White syndrome, there is shortening of the PR interval. Shortening of the PR interval, but long QRS complex, it will be bizarre shaped because of the cell-to-cell conduction at the ventricle. So the PJ interval will not change. The PR interval is shortened, the QRS complex is prolonged, and so it's gathering together, giving a normal PJ interval. And now we will discuss the ECG at the coronary insufficiency or coronary artery occlusion. It is called for sure ischemia, which may lead to necrosis or infarction, and the infarction is eventually followed by fibrosis and the scarring of the heart or part of the heart. This symptom gives the symptoms called angina pectoris, so the severe chest pain when the heart is suffering from ischemia. The ischemia is usually indicated by ST segment changes. As you know that the ST segment is normally isoelectric. The ST segment is normally isoelectric. That means that it should be at the line of the TP line. They should be at the same level and the same plane. While at ischemia, there is an elevation or depression of the ST segment. The elevation gives a hint that we had now an acute infarction following ischemia, while the depression means that we are at ischemia now. And the second indicator of ischemia is the T wave inversion, inverted T wave. Yes. While the third one, which is characteristic of the infarction, is for ischemia, is a Q wave, which will be wide and deep Q wave. When the Q wave will be wide and deep, it will continue and will not improve even after the ischemic attack is resolved. But the ST segment elevation or depression, or even the T wave inversion, are reversible conditions associating the infarction, the ischemia, I'm sorry. When the ischemic attack is resolved, the ST segment and the T wave will gain their normal appearance. But when the Q wave becomes wide and deep, it will cause what is called ECG stigma. Will cause what is called ECG stigma and will appear in the ECG for all over the life. It is a long life stigma of ECG. ST segment This is a normal shape of ECG. This is a normal shape. ST segment is at the TP line, as you've seen, is isoelectric, and where the ST segment, when elevated or depressed, this is the ST segment at the TP line. When it is elevated or depressed, we give hint for the appearance or the presence of ischemia or infarction. The T wave, as seen here, is upright, but when it is inverted, it means that there is an ischemic attack present now. While the third one is the Q wave, which is normally less than half of a small square at its depth, and less than one small square at its width. But when it becomes deep and wide, it indicates the presence of infarction, and it will not disappear from the ECG long life. This is elevated ST segment for sure. Elevated ST segment. And this is depressed ST segment. Look, that the ST segment now is below the level of the TP line, which is the isoelectric line. Here is depressed ST segment. Depressed ST segment. Look to the T wave. Now it is now inverted. It gives an indication of the presence of ischemia. Look to this Q wave. It is deep Q wave, which is a pathological condition. Means that the heart is now becomes infarcted. Okay, diagnostic criteria of acute myocardial infarction: Q wave duration more than 0.04 seconds, more than one small square. Q wave depth more than 25% of the R wave. ST elevation in leads facing the infarction or depression. Deep T wave or inversion of T wave, in addition to the presence of cardiac arrhythmia. Look now, this is the Q wave. All of this is Q wave, very deep Q wave. Here, elevated ST segment that becomes as a bridge and joined to the T wave. This is a T wave which become now depressed. Okay. Elevated ST segment, depressed or inverted T wave, and wide and deep Q wave. Three criteria of the ischemia followed by infarction. Elevated ST segment or depressed ST segment is a misnomer, is a misleading name, because eventually we have the TP line. The TP line is the one that shifted downward, and so we can see the ST segment elevated. I mean that the TP segment is shifted downward, but the ST segment is normal. So when you see that the TP line, the isoelectric line itself become depressed, your eyes, for mistake, will give you the appearance of elevated ST segment. When the TP line is elevated, the ST segment will appear, it looks like it was depressed. So the ST segment is not the one shifted upward or downward, but the TP line or the isoelectric line is the one shifted in this condition. While the T wave is inverted and the depolarization become reversed at its conduction direction. While the Q wave become deep and wide, which indicate the appearance of infarction. Before the injury, there is normal ECG. Appearance of ischemia giving ST segment to depression or elevation with, when it becomes infarcted. Then the T wave will be inverted, and then the infarction become evident when the Q wave appeared look like wide and deep. At A, there is normal ST segment. but at B ST segment there is mild elevation, and as we said that the TB line, which is the one truly depressed and giving a false appearance of the ST segment elevation. Now the ST segment is more elevated, and now ST segment is elevated associated with the inverted T wave. The ST segment regain its line corrected, but the T wave is still inverted, and at the end of the ischemic attack, the ST segment become normal and the T wave become normal. This is the normal ECG, and this is the start of elevation of ST segment, more elevation, T wave inversion, correction of ST segment, and correction of the T wave. The correction, for sure, uh, uh, will be present when the ischemic attack is resolved. This is a sequence of changes during acute myocardial infarction. The first minute, no changes. 1 hour after onset, the ST segment will become elevated. Few hours later on, the T wave become inverted. A day or so after onset, the ST segment elevated and T wave inverted, but the ST segment started to decrease or descend to its normal plane or value. Later changes after the attack become improved. The ST segment become isoelectric. The T wave still now inverted. At the end, few months later, the ST segment become normal and the T wave becomes also normal. But look to the Q wave. This is the normal Q. This is the normal Q, and now the Q wave become longer and deeper and wider than normal, more and more. Yes, no result, not resolved, even after months of the acute myocardial infarction. So it is a permanent change of the ECG, which is a deep and wide Q. This is the infarcted tissue of the ventricle. This is the infarcted tissue. And when we are recording the septal depolarization, which is indicated by the T wave and the ECG, is normally masked by normal muscle. When the muscle was normal, we cannot record the septal depolarization well. But when there is an infarction, the appearance of infarction, this infarcted tissue and the fibrous tissue seem to be like what is called electric window. Electric window, that means that the recording electrode will record the septal depolarization better than usual. And the septum now is recorded deeper and wider than usual because the ventricle is like a window, electric window. And when there is a window open, we can see what is behind. We can now see what is behind the ventricular muscle, which is for sure the septal depolarization. This is the ST segment elevation. As we said that it is not a true elevation, but actually the TB line or the isoelectric line is the depressed one at the ischemia. Depressed ST segment compared to the TB line. In athlete 2, elevated ST segment, more than one small square or even one half of a small square is characteristic of ischemia. ST segment is elevated, looks like a bridge between the QRS complex and the T wave. Elevated ST segment is a sign of infarction. Wide and deep Q is another sign of infarction. Infarction for sure, elevated ST and the breast and inverted T wave and wide and deep Q wave. Look at the V4 and V2, there is elevation of ST segment. giving hint of the presence of ischemia. This is the segment, inverted T wave. Look here, elevated XT segment, inverted T wave, elevated XT segment, inverted T wave, and so on. Normally, as I said, that this muscle masks the septal depolarization, and so the Q wave is shallow and small in depth and in duration. This is a normal P wave. But when there's an infarcted tissue, we can record what is behind the window and see the septal depolarization more than usual, giving high amplitude of the Q wave. Like this. This is the electric window, and this is the infarcted tissue. So we can see the depolarization of the septum more than usual, giving this shape of the Q wave, giving what is called the electric stigma of the ECG. What about the electrolyte disturbance during ECG? Hypocalcemia giving long QT interval, while hypercalcemia giving short QT interval. Hyponatremia, low voltage of the QRS complex. As you know that the QRS complex is denoting the ventricular depolarization depending on the solute. While hypokalemia giving low T wave, prominent T wave, and prolonged PR interval. What is the most important point at this disturbance? It is the hyperkalemia. Hyperkalemia giving tall peak, the T wave, which is a dangerous sign because hyperkalemia may arrest the heart during the diastole. The normal serum of potassium is 3.5 up to 5.3 milliequivalent per liter. When it is increased more than this value, it is called hyperkalemia, and one of its causes is renal failure or due to potassium replacement therapy, for example, giving tall peak the T wave. Look here, this is the T wave at hyperkalemia or peak hyperkalemia, and which now may reach the level of the QRS complex voltage. Yes. This is a tall peak, the T wave, characteristic of the hyperkalemia, and it is a severe condition, an emergency condition, because hyperkalemia may arrest the heart during its diastole. This is another one. Go to the QRS complex and look to the T wave. This is the QRS complex, and this is a T wave. Very, very large, long T wave. Tall peak. At the end, Mr. August Waller, which the first one that discovered the ECG recording, and he said before that I don't imagine electrocardiography is likely to define any very extensive use in the hospital. He was a disappointed man because now the ECG is a regular diagnosis and very important diagnostic maneuver for different diseases, for different disturbances such as ischemic heart, electrolyte disturbance, heart failure, cardiomyopathy, axis deviation, hypertrophy of the heart. Many and many disorders are diagnosed using the ECG. Thank you.